using me, and my topic for today's presentation is lung cancer with EGFR mutation, and especially in Indian context. Starting with my presentation, why this subject becomes important. This subject becomes important because of what we see in the slide. Not a very old slide, and this data was presented in 2002 and published in 2002 in NEJM. What it suggests that not long back, the lung cancer, if you had a stage 4 disease, then outcome was very poor and attitudes towards these patients were nihilistic. The average life of these patients were around 8 months, and we can see at that time the best of the treatment, and what we see here, there were almost 4 treatments which were being compared, which showed that average life of these patients remains around 8 months whatever treatment we use. And I am sure many of us who are here, who are oncologists, won't believe that this kind of paper can come in NEJM and today's time. And that highlights that lot of change in lung cancer during this time. Again, my focus will be today EGFR mutation, so I will be focusing on that same, and especially in Indian context. Another data which becomes important, that why this is important, why this EGFR mutation is important. This is one of our work which we did with our collaborator Dr. Amit Dutt, which works in ACTRAC. We profiled almost around 500 odd patients and try to see which kind of mutations are common in our population. What we see here, that if we compare the kind of mutation which is prevalent in our population as compared to Caucasian population, it looks that mutations are similar with some differences. But what we definitely see, that some of the mutations are far more common, and what we see here, the commonest mutations in lung cancer in adenocarcinoma in our population remains EGFR. So as far as the problem is concerned, that what percentage of patients this problem happens, it is significant. And that is one reason why we are talking about EGFR mutation today. Second, this is our data. Again, in the same paper, what we tried to do is to see that if you have EGFR mutation and if you have given treatment to these patients as compared to the patients who doesn't have EGFR mutation, and what is the outcome of these patients, what we can see distinctly, that the best outcome is in the patient where you do have EGFR mutations and you are able to give targeted therapy for these patients. This is data which is similar to data which is there from Lung Cancer Mutation Consortium, which was the worldwide effort where they tried to see that what kind of mutations you have, and if you give targeted therapy, does the outcome improve. So this again highlights that yes, it happens in our population also. And that again highlights that why we should be understanding this EGFR mutations and how it impacts the treatment of our patients. I got some questions and I'll keep answering, and I'll request people to keep sending the questions. The first question is, which is better in first line CA lung with brain mets, osimertinib, afatinib, dacomitinib? No doubt osimertinib is better because that goes to brain far better than the other treatment. But again, if you are not able to give osimertinib, then TKI is better than giving chemotherapy. So yes, if you can give osimertinib, no doubt we should be giving osimertinib. What is the treatment of meningeal involvement in CA lung after progress from radiation? If you have a meningeal disease, then it is important, if the patient is symptomatic, that we give something intrathecal. What we do is we start with intrathecal methotrexate and maybe we add prednisolone to it. If the patient has got EGFR mutation positive patient, then if you patient another thing what someone can do is, if all the other disease is controlled, to increase the dose of the drug, either increase the dose of gefitinib or erlotinib. Or another thing if one can do is that do T790M mutation in the CSF, which we have done in some patients. If it is positive, you can change this to osimertinib. Otherwise also, osimertinib higher doses has a better penetration than the other drug, and again in this situation one can choose to give osimertinib to these patients. But overall, the outcome is poorer in these patients. Upfront, outcome is not so poor, so one should be aggressively treating these patients. But at the time of progression, the palliation is good, but overall outcome is not very good.